Minimal interruption of compressions, adequate ventilations. 2 breaths after 30 compressions, every time. For possible cardiac arrest rhythms, you have pulseless VT, VTAC, pulseless ventricular fibrillation. You have asystole, and pulseless electrical activity. Key points to remember: if defibrillation is indicated when the provider is giving chest compressions, giving chest compressions should continue while a second rescuer charges the defibrillator. Then pause the CPR, clear the patient, and deliver the shock. Resume chest compressions immediately without pausing for a rhythm or pulse check. After 2 minutes or 5 cycles of CPR, we're going to pause resuscitation efforts and check the rhythm on the monitor. Let's see what we got. If the rhythm is other than VF or VT appears, then identify the new rhythm and check for a pulse. If there is no pulse, move down the algorithm to the asystole PEA pathway and immediately resume CPR. If there is a pulse, move to the appropriate algorithm, whether it's tachycardic, bradycardic, whatever. If the rhythm is VFib or VTAC, resume CPR while charging the defibrillator. Clear the patient and then defibrillate. Minimize rescuer fatigue by switching CPR compressor and ventilator at each end of each 2-minute session of CPR while the rhythm and pulse is being checked. So to maximize the number of compressions delivered per minute, interruptions should not exceed 10 minutes. Using normal saline, attempt to establish your vascular access. If you're unable to get IV access, go the bone route, intraosseous. Vascular access should be achieved without interrupting chest compressions. As soon as IV or IO access has been established, we're going to administer epinephrine. Epinephrine, 1 milligram per milliliter, which is 1 in 10,000, is administered IV or IO every 3 to 5 minutes until pulse returns. Whenever you give medication through a peripheral IV line during CPR, follow it immediately with a 20 milliliter flush of normal saline IV, and then elevate the extremity for 1 to 2 minutes to facilitate delivery of medication to the central circulation. So the whole point, if we're giving medication, it's got a fast half-life, it's gonna act really fast. We need to get it to the heart. So we're putting it in the our AC, left AC right here. Then we're flushing it. We're flushing it with saline to keep pushing it down to get to the heart. And we don't want it to get stuck here, have to fight gravity. Let's use gravity to our advantage by lifting the extremity up. Several options are available for airway management. So you have a bag mask delivery that can be used for resuscitation effort. It's going to be easier to ventilate. For adults, cardiac arrest without an advanced airway, use a 30-to-2 compression ventilation ratio. We're going to ventilate with just enough volume to place visible arrest, chest rise and fall, and deliver each breath of about 1 second. If the decision is made to insert an advanced airway, then identify placement of multiple methods, including waveform, capnography, and secure your tube. Deliver 1 breath every 6 seconds, 10 breaths per minute without interrupting chest compressions. Your capnography is going to measure your CO2 on your patient. Should be reading what you want is somewhere between, I want to say 25 to 45, but then I've also heard 35 to 45. So I have to do more research on that. But you want 25 roughly to 45 millimeters Hg as far as capnography to measure your CO2 output. VFib or pulseless VTAC is that persists after 1 or more shocks is called your refractory VFib or VTAC. An antidysrhythmic such as amiodarone may be considered. Lidocaine may also be considered as an alternative for amiodarone. During the arrest, consider your H's and T's. We're looking at hypothermia, hypoxia, hyperkalemia, hypokalemia, toxicology, thrombosis, cardiac tamponade, and for PALS, we're looking at hypoglycemia, but for some reason not ACLS, whatever, get a blood Accu check anyway. At any point there is ROSC, then assess the patient's vital signs, support the airway, breathing required, and give medications as indicated for regulating the heart rate, controlling your cardiac dysrhythmias, and maintaining your blood pressures. All right, H's and T's. So, what could reverse our antidysrhythmias? Hypovolemia, hypoxemia. Just so I'm not speaking Greek, let's go in detail. Hypovolemia, there's not enough blood pressure. Could be cardiogenic shock, could be hypovolemic shock, hypovolemia. Hypoxemia, not enough oxygen in the blood. The hemoglobins that are transporting oxygen are not getting to the cells, or the oxygen is just not getting to those. Somehow oxygen is not doing internal respiration to the rest of the body. Hypothermia, the cold, that's easy. Hyperkalemia, they have too much potassium in their system. They've eaten too many bananas. Hypokalemia, there's not enough bananas. Hydrogen ions, acidosis, so this we determine with capnography. You could tell if someone is getting too acidic, which if there's not enough respiration happening, right, because of hypoxemia, then the cells are gonna start doing what they do, going through cellular, what do cells do? So your brain cells are doing what brain cells do, your lung cells are functioning how lung cells do, and then through doing that work, they're producing lactic acid because they are not receiving oxygen. So they are running, but not nearly as efficient as they would with oxygen, but they could still run. But through running, it's almost like they destroy themselves running, and now they produce lactic acid that goes through the body. That lactic acid and other waste product gets in the blood. Now you're getting acidic, hydrogen ion acidosis, and that's what we can measure through capnography. Tension pneumothorax, something in the lungs where the lungs are getting too tight. You can oscillate and tell if someone has tension pneumo or not. So if that's happening, we could do needle decompression. I want to say, I need to study this too, but I think it's fifth intercostal space, mid-axillary. You are going to take a needle and stick it just between the space of where the lung is and the perineal lining, perineal sac, whatever it is. The sac that encapsulates the lungs, there's air trapped in there. And you are sticking the needle in so that way the lungs themselves can have space to breathe again, and it gets rid of the air that shouldn't be where it is by bleeding out of the body. You're bleeding the air out of the body. If they still have tension pneumo but the air stops, you're going to get another needle, stick it right next to that one. So your signs, if it is tension pneumo, I guess I could look at these two. Let's just keep going down. So cardiac tamponade, cardiac tamponade. We'll go into that later. That's detailed. Toxic, the drugs can do a lot of different things. So you could have fentanyl. That's most likely what we're going to see on the street. Fentanyl. I should probably have this closer. Could be organophosphate, poisoning as well, thrombosis, massive myocardial infarction, pulmonary embolism. If your patient has an embolism that gets lodged in between where the heart feeds blood to the lungs, they're going to get a pulmonary embolism, and you'll probably see pink sputum. Doesn't say that. But yeah, you could also get a coronary embolism. I don't see it. Maybe that's on the next page. So they could also have a coronary embolism, the coronary arteries that feed the heart instead of feeding the rest of the body. They could have one of those as well. So if they are hypovolemic, then you're going to have a history of flat, they'll have a history of it, but also flat neck veins. So they'll be laying on the ground, and normally you could see somewhat distended jugular JVD. But if they're completely flat, then you know that your issue is probably hypovolemia. So we'll replace with volume. We'll go ahead and give them a 1,000 milliliter bag of saline solution. Hypoxemia, cyanosis, so that could be a problem. Cyanosis, I'm thinking cyanide poisoning. Airway compromise, so we want to at least open their mouths. We're doing a lot of things at this point anyway. Obviously their mouth's going to be open, but make sure that they're not snoring or having any issues like that. So ventilation of 100% oxygen, pulse ox will verify that as well. Make sure it's not carbon monoxide poisoning. So we'll have our other, whatever it's called, I'm not sure what the device is called, that reads carbon monoxide versus O2, but we have that. History of exposure to cold, yeah, cold. Immediate transport if hyperkalemia, hypokalemia. So we're going to use sodium bicarbonate if certain of acidosis. So sodium bicarbonate is going to be a more basic drug that is going to counteract the acidity of the body. So the base turns the acid into water, and I believe salt. Yeah, acid and base turns into water and salt. I remember that from chemistry. But if we give sodium bicarbonate, we will never give calcium chloride through the same access point if we have IV access. Because if you mix sodium bicarbonate with calcium chloride, you get sand, some sort of silicate compound. And now that's in your veins. You just destroyed that blood vessel. Yep, needle decompression. So tension pneumothorax, we want to watch out for all of these. So history, trauma, asthma, COPD. No pulse, but with CPR. Difficult to ventilate if they're struggling. You're trying to ventilate, but like it's not happening. Unequal breath sounds with hyperresonance to percussion on the affected side. So if you listen to both lungs and one sounds clear, the other one sounds like a drum, then you know that it's tight like a drum because there's air lodged in there, and you're gonna get hyperresonance. Yeah. Okay, jugular venous distension, the opposite of flat neck veins. So if they have cardiac tamponade, then the blood is getting backed up through one of their main carotid arteries right here, and you're gonna see them distended. They're gonna be inflated. No pulse with CPR, yes. So immediate transport to pericardiocentesis for pericardiocentesis, cardiac tamponade. And then Narcan, obviously naloxone if fentanyl overdose or any other opioid overdose. Let's take a break.